my take is to clearly speak on pelvic support osteotomy, exactly opposite of what Dr. Alric has just said. And all of you all have been referring to these various classification, and it's so tough to really sort of correlate. And I found this wonderful article in our very own International Journal of Pediatric Orthopedics, where it's all put together into one table. So here we are. So what are we talking about is loss of capital femoral epiphysis, neck, and where does this fall in other classifications? And essentially, these are the type of patients that we are talking about. So I spoke to Sandeep actually, what exactly am I supposed to talk? So he said it was more about the Elizaro hip reconstruction. So as I read, I found that the pelvic support osteotomy as a concept has been in from 1940s. And only from the 1990s did the Elizaro version started coming in. And the main difference that I understood from my reading was that it was all very simultaneous. Now, you could give a very, very high level of valgus. You could simultaneously give the distal varus and maintain the mechanical axis. Also, the other advantages in IHR where the osteotomies could be all percute and there was virtually hardly any blood loss. And, in the present era of THR now in 2022, we really need to know that whether we should keep doing these pelvic support osteotomies or not. So this is one of the best well-read and most published article on pelvic support osteotomy. And this is like the most famous illustration, which actually tells us that in absence of an head and neck, how you want to do a full adduction view and then add further 10 to 15 degrees to the amount of adduction that you get. And then that's the amount of valgus. So it's a very significant amount of valgus. It's very difficult to do it with an open surgery with plating, and actually only Elizaro it's possible to give that much amount of valgus. To sort of give a classic case of pelvic support osteotomy, I found it was absolutely impossible without the help of Dr. Mangal Parihar. So I have taken his help, and it's very important to know that when you're doing an Elizaro hip reconstruction, either with Elizaro or with an LRS, the cora for your distal femoral varus is very, very vital, and that can make or break your final outcome. And it's way proximal than what we visualize. Normally you would want to think that I would want to do it at a metaphysio-diaphyseal junction, but actually it's like way into the diaphysis, and this central segment is very small. And Dr. Mangal Parihar in his talk has given many illustrations of how if you miss the cora, then the mechanical axis does not really align well at the end of the treatment. I begin with one of his case, which falls well within the classification of what sir has mentioned. So this was a 10-year-old boy, Dr. Mangal's patient, and with all possible problems, sequelae of sepsis. And he went ahead and did the pelvic support osteotomy using a LRS. And the mechanical axis was well maintained. The main thing was that he had very poor regenerate quality, and he could not tolerate the fixator for that long length of time. So the bridging plate was used. So this is a very good add-on tool to cut short the fixator time in pelvic support osteotomy. This is his gait video, and you can see that there's very minimal lurch that he has now in both the views. Now I'll go to one case which I did. This guy was about 16 years old. He's about 23, 24 now. And I was fairly confident that I'll be able to do a good job at this. So I went ahead and I did it with the LRS. I felt everything was going well. There was a problem. He could not tolerate the proximal pins. And I felt that probably this proximal part has now got consolidated, so I can probably remove that part of the fixator and just continue with the distal lengthening. So this is a good learning lesson that I had at that time. And in spite of attempting to distract again and again and again, I just could not distract anymore. What was happening was that I was actually straightening out my pelvic support osteotomy. So instead of getting about 5.5 centimeters of lengthening, I had to stop at about 2.5 centimeters of lengthening, which actually made this case suboptimal. I went in, redid the proximal valgus, and I got his videos from now. He has significant shortening, but I did ask him, and unfortunately, I don't have his absolute pre-operative video. He still feels he's about 60% better. So even a half-done pelvic support osteotomy uh, with an inadequate lengthening seems to have worked in him. Now, in this patient, for the want of anything better and not having the guts to be able to do a trochanteric arthroplasty, I did a pelvic support osteotomy. A very young child, roughly 3 years of age. And I kept on holding on to the plate, but I thought that even with the plate, there was remodeling. So I removed the plate and he's remodeled significantly. But if you see his video, he is doing well with very minimal lurch, and with a small raise, you can virtually not make out anything is happening to him. And if I ask his parents, they feel he's about 70% better if we had not operated him. So this is one case shared by Jayan Sampath, and again same head neck issues and his excellent outcome of a pelvic support osteotomy with a very good gait, very minimal lurch. So this was another very good article. It's coming from Pakistan actually. So they have discovered the whole role of THR versus PSO, and they recommend that the ideal age at which PSO should be done from their own experience and their review of previous literature is roughly 15 to 16. And the level at which the PSO should be done is at the level of the ischial tuberosity. Level of lengthening I've already discussed. Distal varus lengthening we've already discussed. And a significant amount of valgus has to be given in order to prevent the Trendelenburg gait, and the total amount of lengthening done in the mechanical axis maintaining is extremely important. If also possible, you should do a very ideal proximal osteotomy, correcting it in all three planes, and you have to have your pins really preventing the knee stiffness. So I feel it's a very tall order. We say that I want to do a pelvic support osteotomy with lengthening of 5.56 centimeters in a 15-year-old person, but it's a very tall order. It's not easy. You require a lot of counseling. It can take up to a year of fixator, and I feel application of fixator is probably even less than 30% of the work. If you can really execute it well, then it's very gratifying. 2 points at this juncture is I asked few of the arthroplasty surgeons whether they can ever revise a pelvic support osteotomy, Ilizaro hip reconstruction patient into a total hip. They say currently they could, but it would involve a lot of work. So even a IHR patient can be revised into a total hip if he experiences pain. Thanks a lot.